Hi, everyone. Can you hear me? I'm sorry if you're offended by this slide. So, as Martha mentioned, I'm coming from Belgium, but I'm from Texas. I'm sorry about that too. Um, I come from a land that has lots of big things. We have our Big Bend Park. We have our big rockets. I come from Houston. This is me and my daughter next to a SpaceX rocket at NASA. And we like our big portions, right? Here, the portions are smaller. And we have big problems. To say Houston, we have a problem. Yeah, we have a problem. Drug resistance, of course. Houston was a hot spot for antibiotic resistance. They have lots of superbugs there, but the whole world really has superbugs. The WHO used to call this an invisible pandemic. They call this a global epidemic. And the numbers are really kind of, telling us this too. 1.22 million deaths due to bacterial AMR in 2019. And I used to show this slide, but now the WHO, I didn't know you were going to be here. They're starting to realize they know the problem. I think they know the solution, right? And I agree. They're starting to do a lot more going into looking at how phage can help us in health and agriculture. They actually have this group. It's called the bacteriophage group, which you can join. You can just probably Google it. And there's lots of information about talks and papers. So today I'm going to talk to you about synergy, or in my previous lab we called it synography. It's a method to determine a phage and antibiotic synergy. It was developed by a student, now postdoc at Baylor College of Medicine. And she used a simple plate reader, and she incubated phage and antibiotics and bacteria together in different concentrations, and simply measured the optical density of the growth of the control minus the treatment divided by the control times 100. And from this information, you can make a nice histogram, or we called it a synogram. So you can see here the darker color indicates 0% reduction in bacterial growth, and the white indicates 100%. And then the x-axis is the phage concentration, and the y-axis is the antibiotic concentration. So you can see here, when you combine both, you have nice white and nice synergy. And here, where as you go up in phage and then you go up in antibiotic, you see dark, so suggestive of maybe antagonism or not synergy. And what she found, and what many others have found, is that this synergy is, she couldn't find a pattern. So it seemed to be dependent on the bacteria, the phage, and the antibiotic, which means that you have to test this every time before you treat a patient. And we did this at Baylor. We were able to help facilitate the treatment of 12 patient cases through the expanded access program with approval, not technically approved by the FDA, but approval for expanded access for these patient cases. It was various treatments for UTI, bacteremia, prosthetic joint infections, different wound infections, different device infections with different bacteria, Staph aureus, E. coli, Klebsiella, Pseudomonas. The clinicians, they treated with the phage, customized phage that we had, all via IV, but also in combination at the site of infection and IV. And more importantly, they were treated concomitantly with antibiotics. And so we produced these synograms, and we sent them out to the FDA for this expanded access approval. So they're very happy to see that we're looking at synergy, not just whether the phage can infect the bacteria. And in all of the cases, we saw at least no antagonism, except for one. There was one that I showed you earlier where you go up in phage concentration and you add antibiotic and it starts to darken. But luckily, the clinician had the choice of antibiotics where she saw synergy, and she went with the one where she saw synergy. And it ended up being a very successful case. Among these cases, we like to categorize favorable microbiological outcome versus clinical outcome because it can be very complex. Microbiological is very, you see bacteria or you don't on a plate, whereas clinical outcome, it's based on the experience of the clinician and what she thinks. So oftentimes, these can differ. So we saw 42% favorable microbiological outcome and 58% favorable clinical outcome. So these numbers, they may seem very low, but some of these patients had been on antibiotics for decades. These are some of the most difficult cases you probably see if you're a clinician working in infectious disease. And the thing about in the US is that, yes, we have this expanded access program, but it's not ideal. We had some patients, you could see, that waited up to 2 years to get their treatment. There are cases where you can get phage therapy right away within 24 hours, but those are only very emergency cases. So it really can be a time-consuming process. And so these patients, they don't have time. So I think there's a better way to do this. And so I'm in Belgium now, and I really like it. They have nice fries and chocolate and beer, but they also have a nice phage program. And they have a different way of implementing phage therapy. It's kind of based on a regulatory process that was already in place, but they kind of just fit phage into it. So this is the magistral preparations, or compounding pharmacies, as we call it. And so through this process, they have a phage bank, characterized phages that they're always updating. They have controlled labs that produce the phages for the patient, and they have other labs that approve and they test these phage preparations. And then they're sent to hospital pharmacies where the pharmacist can prepare them. And so, and they're allowed to prescribe phages, so the patient doesn't have to wait very long. So I like to promote Belgium and call it the Phage Valley. For the past decade, they've been really building a lot of experience within this field. Yeah, very proud to be a part of this group. And I'm very proud of this paper that was published. They went through 100 consecutive cases that they helped facilitate. I like to also say it was a Belgian consortium mainly by Dr. Jean-Paul Pernet and Rob Leuven and Peter Jan Sessens were really important to facilitate these patient cases. I was able to help out a little bit on the sequencing of some of these cases. So this, for 23 bacterial samples, they saw potential resistance emergence. Oh, they assessed 23 cases that had samples. 7 had a resistance phenotype, and 5 cases needed assessment because 2 were already published. That's 21 Pseudomonas aeruginosa isolates. We perform sequencing combination of Illumina and nanopore, hybrid assembly. You get some nice contigs. It gives you kind of an overview of the plasmids and the prophage also present. And we compare it to the resistors by looking at SNPs. So you see a lot of talks about resistance, and you say, oh, bacteria have so many ways of resisting phage. Almost every day I see a paper about a new mechanism. But what we see in a patient is that really the mutation is always receptor mediated when we see resistance. So we know this because if you use a phage and you know its receptor, it's really easy to then scour these genomes to see, yeah, where was the change. So this one uses the type 4 pili. It's called PNM. And when we see a resistor, you see a mutation in PIL-C, so part of the type 4 pilus. When we use this phage again, PNM, on another patient, again, we see a mutation, but this time in PIL-R, but it's a two-component system, also required for the regulation of the type 4 pilus. And we also try to look at the costs to virulence. So we use the Galeria model system. And what we find is when we take these mutants and we infect these Galeria, at least for this one where we saw a SNP in PIL-C, we really see that there was no significant reduction in mortality. And this patient did not improve clinically. So yeah, maybe that's why. Yeah, maybe the bacteria resisted the phage, and it also didn't seem to come at a cost to virulence. However, this patient did improve clinically, but we saw some difference in mortality, but really it was just a little delay. So within 18 hours, all the Galeria died. So what do you see when you use 3 phages that target 3 different receptors? So you see this in the literature too, where you should not see resistance, but no, we see this. We see resistance to all 3 phages. So PNM, we see a mutation in FIMV. For 14.1, which targets LPS, we see mutations in this inner core assembly of LPS. And for this phage PT07, which has not been characterized as well as the other phages, but is very similar to another phage that we know targets an efflux pump, we see a mutation in MEX-B, which is part of the inner membrane of this efflux pump. But we also see a mutation in gyrase A within this quinolone resistance determining region. So you have 2 regions where your major mechanisms that Pseudomonas uses to resist quinolones, and you see mutations in those, it actually leads to a decrease in the MIC level from 4 to 0.5 for ciprofloxacin, 8 to 1 microgram per mil for levofloxacin. So yeah, you see resistance to all 3 phages, but then you see this resusceptibility to antibiotics. And looking at the cost to virulence, again, we use the Galeria model also for these mutations, particularly the ones where you have multiple genes affected. We see a really significant reduction in mortality. They survive for 48 hours. And yeah, it's usually mutations in LPS, type 4 pillets, and MEX combined. We're a Pseudomonas lab, so we looked at this further, performing the classical motility assays. Again, that patient 30 where the patient didn't get better and it seemed to not come at a cost of virulence. We don't see changes in the motility assays. But for this patient 54, where the patient did get better, There was a slight reduction in mortality. We do seem to see some changes, at least in twitching and the swarming assays. Got it. And for this patient 91 that had multiple mutations, we also see some deficiencies in motility too. And so we don't know, though, whether, yeah, these bacteria, they're not motile, but maybe they could be forming biofilms. So that's for further research. For the other two patients, it's very clear that the bacteria was a different bacteria. So still Pseudomonas, but a different isolate. So it makes sense. The phage cannot infect this different strain, and so it's not going to work. And then for this patient too as well. So both patients clinically improve, and we think that the reason why is because of this, right? The patient was on antibiotics. So phage are very specific. So you have to give them antibiotics as well in case something like this comes up where you have maybe another bacterial strain that will infect the patient. So I went through two major studies that kind of had this similar conclusion, and don't have that much time. But we are also looking at other types of phage therapy treatment for HS. This is a chronic inflammatory disease. It's very complex with the skin microbiome involved, so it's hard to find the causative pathogen. But there is precedent for using phage therapy. They use it at Eliava as well. And we're beginning to understand the microbiome of these patients, as well as the virome. And we've trained a phage to help a patient that has HS, and they have been improving clinically. So it's been a success so far. And so thank you. I'm out of time.